Right, you can start, Mahesh. Eros in surgery.
Good evening, everyone. Today we are going to discuss about the enhanced recovery in surgery, which is an important question or a recent advances question for the postgraduate examination. So we will just look into the various features of this process or protocol and see whether we can implement in our day-to-day life or day-to-day surgical procedures. Enhanced recovery of surgery, otherwise called as ERAS, is a firmly established as a goal surgical quality improvement pathway. The result of this pathway is to improve clinical outcome, reduce hospital stay, as well as ultimately reducing the cost to individuals as well as to the country. It is estimated that around roughly 234 million surgeries are performed globally, and 1 in 5 of them are expected to suffer some post-surgical complications. It was this protocol or this thought process was first uh, uh, conceived by Mr. Dr. Professor Henrik Hellet, professor of perioperative therapy at Roosevelt Copenhagen University, introduced the concept of enhanced recovery pathway in 2002. This approach was also previously called as fast-track surgery or enhanced recovery program. It is a multimodal care team required, and not only surgeons, but various other uh, department professionals are involved in this protocol. So what is ERAS or enhanced recovery after surgery? This protocol or multimodal perioperative care pathway designed to achieve early recovery after surgical procedure by maintaining a preoperative organ function and reducing the profound stress response following surgery. ERAS was otherwise called as also fast track program, has been an important focus of perioperative management after colorectal surgery, vascular surgery, cancer surgeries. They have been implemented in various breast surgeries and thoracic surgeries, and most recently and in also in the radical cystectomy procedures. There are various other articles indicating the application or use of ERAS protocols in many other surgeries, which are going to come in a great way in future. The original ERA question raised by Professor Henrik Kellett was whether mitigation of surgical stress response led to accelerated convalescence and improved surgical outcomes. Dr. Kellett works focused largely on patients' education and activation and attenuation of surgical stress response through aggressive pain relief modalities, early enteral nutrition, and early mobilization. The global healthcare community has come a long way since 2002 uh, in numerous surgical centers adopting this simple protocol called ERAS protocol. There are various components are mentioned in ERAS, which are common across many medical specialties. The ERAS program or protocol is broken down into three main components. They are preoperative, intraoperative, and postoperative. It is multifaceted approach that can be used for all kind of patients. The goal is for anyone undergoing surgery to benefit from this process and from enhanced recovery. The first ERA Society meet was conducted in Stockholm in 2010, and it was first implemented as a program in Sweden in the Oberor University Hospital. Some key features to remember in ERAS protocol are important thing is a thorough preoperative counseling, a good nutritional assessment and optimization, a standardized analgesic and anesthetic regime in coordination with the anesthetist, and an early mobilization involving the hospital physiotherapist and preoperative counseling involving what to expect from and during and after surgery. So who are all the members of this ERAS program? So if you can see most of the important members in all your other surgeries like nurses, dietitians, physiotherapists, pain specialists, anesthetists, surgeons, and hospital management are involved, are the important members of the ERAS team. If you look at it, most of the hospital departments are involved. And so it is nothing new. It is just that it requires a channel or a program to work towards early recovery and less morbidity and mortality of the patients following any kind of surgeries. So coming to the various components, first we will discuss about the preoperative components. So this preoperative component starts as soon as one is diagnosed to have a surgery and they have agreed for a surgery. So a thorough patient education and counseling involving the relatives should be provided by the surgeon, and allied health specialties could be a nurse specialist or in terms of colon surgeries like a colorectal nurse or a ostomy nurse. So all of them should thoroughly counsel these patients to begin with. So prehabilitation is very, very important in ERAS protocol. The optimization of patient health before surgery is very important, be it physical fitness or nutrition. So it all comes under the prehabilitation of these patients who are undergoing for surgery. Common salient things like anemia, if it is there, should be investigated and treated thoroughly before surgery. Smoking and alcohol should be recommended to cease before 4 weeks of surgery. Evaluation of ceasing hormonal replacement therapy and oral contraceptive pills and any other medication which needs to be optimized should be discussed. A thorough nutritional counseling should be discussed along with the dietitian, and uh, also there should be care taken to discuss about to avoid post-operative prolonged fasting. Antibiotic prophylaxis should be discussed. Then carbohydrate drink prior to surgery, otherwise called as the carbohydrate loading, should be recommended and is a part of the ERAS protocol. And also there should be a evaluation of appropriate bowel preparation, whether they are required or not. So these are the preoperative components which should be looked into it when implementing the ERAS protocol before surgery.
Mahesh, you want to stop and take any questions?
Yes, sir.
Anybody has any questions, doubts? Or
Sir,
trade name of carbohydrate drink?
It will
It
come, sir.
is pre-carb.
It will come, sir. It come. I'll
Sir,
mention.
Ajit here, sir.
Yes.
Sir, for bariatric surgery, can we apply ERAS, sir?
Actually,
Yes.
it started actually with the bariatric surgery. The use of ERAS protocol is becoming famous or is becoming popular, and various bariatric centers are using this ERAS protocol that includes carbohydrate loading and planning and post-operative pain relief and early feeding. So it is very much practiced in bariatric surgery.
Okay, sir. Thank you.
There are RCTs done regarding that. They have given good report. Yeah. Any difference between fast track surgery and EROS?
Fast track surgery was actually individually programmed, sir, and there was no consensus or protocol before ERAS was implemented. So ERAS is one step ahead of fast track, wherein there is set protocol and there is a body that is ERAS society, which dictates or recommends the protocols or the guidelines to follow.
Basically, fast track surgery started with the colorectal, and this is more concentrated or directed towards early discharge. But now it's almost everything is together. So EROS has basically looks into entire gamut of perioperative care, preoperative, intraoperative, postoperative, and everything is written, documented, and it is evidence-based and also multidisciplinary team managed. I think that's the basic difference between these two. Right, Mahesh?
Yes, sir, correct, sir. Yes, sir. It's all streamlined with the ERAS, sir, actually.
How many days should the patient stop OCP? Oral contraceptive pills. I think Mahesh will come to all these things later. Prior to surgery, when do we give the carbohydrate drink? We keep patients NPO 4 to 6 hours prior to surgery. You want to take this, Mahesh?
Regarding this, I will a detailed discussion is there in the further slides, sir.
Okay,
When we
okay.
come to the nutritional aspect of it and pre-carb loading.
Okay. Any other questions? All right, then we'll move on.
Yeah. So as we all know, poor nutrition is detrimental to the outcomes of any surgery post-operatively. So nutrition should be addressed very strongly, and the ERAS guidelines have given definite guidelines in taking care of the nutrition of the patients. The assessment and treatment of poor nutrition is an essential component. Correction of preoperative nutritional deficiency may sometimes require prolonged parenteral or a combined parenteral enteral nutrition, depending on the severity of the problem and also the patient's gastrointestinal functions. Most cases, a patient may be managed with appropriate input from a experienced nutritionist and the use of standard whole protein liquid nutritional supplements. So coming to the traditional practice of preoperative fasting, the practice of fasting patients from midnight is used to avoid pulmonary aspiration after elective surgery. But over a period of time, this has been found that there is no evidence for this practice. It actually causes increased metabolic stress, leading to hyperglycemia and established insulin resistance, which the body is already prone during the surgical stress. The changing the metabolic state of the patient by shortening the preoperative fasting not only decreases the insulin resistance, but reduces the wasting, that is the protein loss, and improves muscle function. Early feeding postoperatively also prevents the reduced risk of paralytic ileus and the risk of which could be as high as 30%, especially in cancer surgeries. So coming to the interesting topic about carbohydrate loading and early enteral feeding, the stress response of surgery is initiated by a variety of physical insults such as tissue injury, infection, and hypovolemia or hypoxia. The ERAS program is aimed at attenuating the body's response to surgery, which is characterized by its catabolic effect. So what happens during fasting? The autonomic afferent impulse from the area of injury or trauma stimulates the hypothalamus pituitary adrenal axis and mediates the body's subsequent endocrine response. This in turn causes increased corticosteroid levels, leading to gluconeogenesis and glycogenolysis in the liver. These hormones and cortisol production leads to a protein catabolism wherein there is weight loss and muscle wasting and also nitrogen loss. Hyperglycemia is therefore a significant finding after major surgeries, and the observed insulin resistance is a major variable influencing length to stay and leading to poor wound healing and increased risk of infection and complications. The degree of insulin resistance is associated with the kind of surgery, and if the post-operative hyperglycemia is controlled, the mortality and morbidity can be reduced by half, wherein which many studies have shown this phenomenon. The method which reduces the insulin resistance includes adequate pain management and reducing the pre-op fasting and use of carbohydrate loading. So basically the fasting which everybody practices or still many of us are practicing does not have much evidence, and most of the centers are leaving this behind and following the ERAS method of fasting before surgery for most of the surgeries. So what is carbohydrate loading? The use of carbohydrate loading attenuates post-operative insulin resistance, reduces the nitrogen and protein loss, and preserves the skeletal muscle mass, and reduces the preoperative thirst, hunger, and anxiety. It involves use of clear carbohydrate the day prior to the surgery, up to 2 hours before surgery. This carbohydrate loading should be discussed with the anesthesia team and the nursing team, and should be kept as a protocol in the surgical team so that it is implemented and practiced properly with specific time duration. Apart from metabolic effect, it facilitates accelerated recovery through an early return to bowel function, which leads to shorter hospital stay and leading to improved perioperative well-being. As a result, it is an important element of nutritional aspect of ERAS and should replace the practice of overnight fasting, which I mentioned earlier. So these are the various proprietary products are available. At Astor Hospital, we practice this pre-carb ready mix, which is given 2 hours prior to the surgery, first in the morning. And as I mentioned, this is a pure carbohydrate drink, reducing stress, anxiety, and post-operative issues with the patients. So, any questions, sir, at this level?
Okay. Anything, Dr. Nos? See what anesthetists say is 3 hours fasting, max 2 hours, maximum 3 hours fasting is enough. They are okay to give clear liquid 2 hours prior to surgery. As a precaution, we give 3 hours before surgery. So nothing, no milk or no coffee, tea, nothing. But this is a pure carbohydrate liquid can be given 3 hours prior to surgery. And as he said, previous day night, 12 hours before surgery. Because the surgeries are fixed and times sometimes difficult, what we do is tell them to take morning at 6 o'clock. Most of the surgeries start at 9 o'clock or so, so there is no objection from the anesthetist. What about hyperglycemia that it may cause in diabetics? Mahesh?
With am I audible, sir?
Yeah. Yes.
Yeah. It is studies have been found that carbohydrate load actually with the pure carbohydrate ding does not cause much of a hyperglycemia, though the patients are fasting overnight. So it is recommended that to check the uh, fasting blood glucose as well as post-operatively after this carbohydrate ding. So it doesn't cause much of a increased blood sugar levels.
True. There are studies, I think, in diabetic patients, unless it's uncontrolled diabetics, uh, carbohydrate loading can be done in diabetic patients also. Okay. Any other questions?
Sir, what is the cost of that drink?
That is 200 rupees.
Okay, sir.
Ajit, yeah. Not very expensive. Only thing is we have to change our mindset.
So what is the volume of fluid given, sir? Volume.
It's 200 ml.
Yes, sir.
200 ml water to be mixed with this powder. So this content itself is about 150 or 200 ml.
180 ml the jars are actually. So it is a powder. You can just add water into that and mix it and have it actually. So the bottle capacity is maximum is 200 ml, sir.
Right, right. Okay. All right, Mahesh. Next, we'll go on.
Okay. So one more component in the preoperative of the preoperative component is the role of mechanical bowel preparation has been strongly studied and various changes have been implemented in the ERAS protocol. A routine practice of mechanical bowel preparation has been challenged over 30 years and many centers have left it behind or not practicing at all. So what happens with the mechanical bowel preparation, especially in gastrointestinal surgery where we want to give this? So in ideal situation, this mechanical bowel preparation liquefies the solid feces, which actually may increase the risk of intraoperative spillage during anastomosis or resection of the bowel. It is almost impossible to reduce the bacterial load in the bowel due to vast number of microorganisms present in the digestive tract. It causes metabolic and electrolyte imbalance, dehydration, and bloating and abdominal pain related to the bowel preparation chemicals. It is also likely associated with increased complications, particularly risk of anastomotic leak. There has been higher incidence of post-operative ileus, slower commencement of diet, greater risk of wound adhesions, and leading to longer hospital stay. So the mechanical bowel preparation has been almost gone into disrepute or been less practiced, and is not and it is recommended to not to keep it as minimal as possible, or not to practice at all with when you're practicing the ERAS protocol. So there finishes the pre-operative components. So let us discuss about the various intraoperative components in which the ERAS protocol recommendations are looked into it.
Hello, sir.
Yes, sir.
Yeah, this is Saurabh, sir. Sir, although preoperative bowel preparation has been disregarded, but my question, there is one study that advises the use of preoperative antibiotics, sir. Intestinal luminal antibiotics.
Oral.
Oral, yes, sir.
Neomycin. Neomycin.
Yeah, no, what he's talking about mechanical bowel preparation.
Yes, sir.
What you are telling is the pharmacological preparation.
Prophylaxis.
Yeah,
Yes, sir.
that is accepted. That is well studied also, I think.
Yes, sir.
So mechanical bowel preparation. What about mechanical bowel preparation in laparoscopic surgery? Is it required? Saurav, what do you say?
No, no, sir.
One in both open and laparoscopic also.
Sir, I don't think in recent studies anywhere they have mentioned the need for mechanical bowel. Yes.
Right.
Except for rectal surgeries, sir.
Rectal surgeries, right. No, rectal surgeries, you do full bowel preparation or only the rectum?
Rectal enemas.
So only enemas, sir. Rectum.
Enemas.
Rectum should be empty at the time of surgery.
Yes, sir.
Right. And the pharmacological preparation is really useful. Most of the studies say that it is useful to do that. Dr. Lakshman, your opinion on this?
I must confess that I still prepare my bowel, even though I agree that overwhelming evidence is that there is no need for a mechanical preparation. Yeah.
Right.
Yeah.
But you do the oral antibiotics also?
It's very difficult to get neomycin. You know, everybody talks about neomycin. It's not available. Okay. So the other alternative is to use some other unabsorbable antibiotic, but you can also depend on intravenous preparation. So routine perioperative antibiotic cover, you know, prophylaxis is given. The mechanical preparation is always a contentious issue, but yes, if you look at the data, there is no justification for it. Yeah.
Right. Okay, Mahesh.
Okay. So coming to the intraoperative components, the venous thromboprophylaxis with either drugs along with drugs, as well as mechanical cough muscle compressors or the DVT appliances should be used. And then in various recommended cases wherein patients are recommended as high risk, this venous thromboembolism should be extended up to 28 days in the form of injection or tablets, which are recently available. Several skin and soft tissue infection reduction bundles have been suggested and are an integral part of the enhanced care pathway. That means like antimicrobial prophylaxis, usually commonly used as cephalosporins, skin preparation by chlorhexidine-based soaps, shower prior to surgery, and chlorhexidine alcohol skin preparation in the operating room. And during surgery, prevention of perioperative hypothermia by active intraoperative warming using bear hugs or back warmers, and also using pre-warmed parenteral fluids. Avoidance of tubes and drains should be practiced, and also during surgery, control of perioperative hyperglycemia, which is produced due to stress or insulin resistance, should be taken care. And also, as these things have helped in effectively changing the mortality and morbidity of the patients totally. The use of short-acting anesthetics by the anesthetist, monitoring the neuromuscular block depth and complete reversal at the time of extubation should be recommended. There is a recommendation for ventilation, like which is a protective strategy with the tidal volume of 6 to 8 ml per kg and the positive PEEP of 6 to 8 centimeter of water. Preferably wherever possible, minimal invasive surgery, that is laparoscopic or robotic, should be practiced wherever possible, which would help in implementing the ERAS protocol as well as to have a good result in the post-operative recovery time is recommended. So coming to the various small things like intravenous fluids, the recommendation by the ERAS is to have goal-directed fluid therapy. So what is goal-directed fluid therapy? Goal-directed fluid therapy may facilitate by using minimal invasive hemodynamic monitors to monitoring to detect flow-related parameters or dynamic parameters of fluid responsiveness. So the fluid and the response of the fluid should be managed, should be micromanaged. And this is done in order to titrate therapeutic interventions to optimize end organ tissue perfusion, which is important to implement as compared with the patient with a traditional surgical pathway. At the same time, this is because the ERAS patients maintain a better hydration and a normal intravascular status because of carbohydrate loading and the practice of reduced fasting for these kind of patients. So the management of fluid as well as the inotropes and various anesthesia drugs play an important role in these patients and should be micromanaged to have a good result in the end. Analgesics also plays an important role. A multimodal post-operative analgesic protocol has been recommended to reduce the overall opioid administration. This is usually achieved by non-opioid oral medications as well as injections. Wherever necessary, post-operatively, ultrasound-guided nerve or feed block should be selected. And also, epidural anesthesia should be very selective rather than having a wider area of control. Other components in the post-operative period, like the Foley's.
Mahesh, just
yeah, we'll take some questions in this, sir.
Is there any need for pre-operative anxiolytics?
In particular cases where there has been evidence of increased blood pressure or any other situations where patient is very anxious, they may require. But these things will be taken care in the preoperative thorough counseling. And if we get to know about it, they are optimized before admitting.
Or most of the drugs which are not required will be avoided. If
Yes,
you
sir.
are seeing this protocol also,
Yes,
most of the drugs, opioids, and the IV fluids control is very tight.
Very important, sir. Yes, sir. Yes.
Very strict, and they don't give extra IV fluids or anything. And most of the unnecessary things, whether it is nasogastric tube,
Yes,
or the Foley's catheter or drain, all these things, as much as possible, they are avoided unless it is really required.
Okay, sir.
Any other questions? 5% dextrose or DNS versus carb drink prior to surgery. Kushal, you're asking about drinking, is it? Or 5% dextrose IV fluids, DNS?
Good evening, sir. Sir, the thing I wanted to know whether it is because sir said to maintain, we don't want to keep them on a fasting status. Whether we can use IV fluid 5% dextrose or DNS versus the use of the carb drink, which sir has said as per the ERAS protocol, sir.
No. They are entirely different. Pre-operative IV fluid should be avoided. Okay. So this can cause sudden hyperglycemia. But if you are giving a carbohydrate drink, which goes through the intestine and then metabolized through the liver, and then goes to the blood and all. No, that reduces the insulin resistance. That's the concept. And it gives nutrition to the patient.
So also when saying nutrition to the patient, are we looking at the nutrition to the gut mucosa, sir, because we want to avoid mucosal erosions because of post-op NBM status, or how is it, sir?
Absolutely. That also happens when you give the carb drink through the oral route, no, through the gut route.
It suits the gut, actually.
Sir, minimizing the duration of NBM actually overall reduces the surgical stress, as sir had already mentioned.
Yes.
And secondly, the longer we keep the patient NPO, the chances of bacterial migration through anastomotic site, all those will increase, sir. So better to minimize the duration of NBM, sir. That way, sir. So in that case, there is oral is much better than giving a dextrose IV load before surgery.
Very rightly said, Saurabh. Actually, all these things are approved in 70s and 80s with RCT, everything. Only thing is we are not practicing.
Correct, sir. Yes, sir.
And also excessive fluid can cause tissue edema and can lead to anastomotic leaks. Chances of anastomotic leaks are all more when more fluid is given operatively also.
Bowel edema. Sutures become loose. Okay. Right.
Yeah.
Carry
So,
on.
we'll discuss about the post-operative components, which have already been shortly discussed. Urinary catheters should be removed on the day of surgery or post-op day 1. Patients should be encouraged to move around on the same day of surgery. Post-operatively, the diet or the early feeding helps with a high protein diet in mind. Drains to be removed, if put to be removed as soon as early as possible. Management of nausea and vomiting is very, very important. Patient control analgesia, transition to oral medicines on day 1 is recommended. Appropriate venous thromboembolism prophylaxis, as mentioned earlier. Then avoidance of nasogastric suction or intra-abdominal drains as far as possible. At the same time, the ERAS recommends that patients should complete a diary or maintain a diary or document to their diet and how mobile they were after surgery, which will help in auditing the protocol as well as helps in improving the method and optimization of the patients with this protocol. So coming to various components of post-operative issues which can be handled well or which can be optimized, the important thing is post-operative paralytic ileus. Use of routine nasogastric decompression should be avoided after surgery. The incidence of fever and atelectasis, pneumonia are increased with nasogastric tube drainage. Factors that help reduce this include epidural anesthesia, minimally invasive surgeries, gentle tissue handling during surgery, avoiding fluid overload and encouraging early feeding. The NG tubes should be removed just before extubation so that patients are not stressed with these tubes. There are some small recommendations and studies strongly suggesting chewing gums has been helped in attempting an improved post-operative recovery after bowel function, which actually increases the cephalovagal stimulation, leading to secretion of various gastric juices and pancreatic juices, which can prevent paralytic ileus. And there is some studies which have done with sipping of black coffee, which has helped the reduction of post-operative ileus by less than by 10% compared to a comparative study between non-coffee sipping post-operatively. So these are some small studies which has been done with respect to control the post-operative ileus. So NG tube avoiding and also leading to like handling the patient or removing the NG tube just before extubation are all recommended in the ERAS protocol. Any questions here?
Yes. Anything postgraduates? Dr. Lakshman has put a lot of material, right?
No, I just put up some excerpts from a reference on ERAS on a 2017 article. There is still controversy about mechanical bowel preparation, and one of these articles in the in the anesthesia clinics mentions that this recommendation may have to be revisited. They have shown that bowel preparation plus antibiotics have the best outcomes as far as SSI is concerned. This is controversial, but I must admit the official ERAS protocol does say that mechanical bowel preparation is not required. And there is a very clear mention that anxiolytics are not recommended in the ERAS program.
Yes.
Yeah.
Actually, this ERAS society is very well organized. They have a website, they conduct training courses, everything. And there are many centers all over the world where ERAS protocols are strictly followed in hospitals. Any other
Mentioned that
questions?
website and all in the end, sir. Actually, it is there. So it is
Right,
the
right.
website and audit website is there. Links are there. Yes.
Right. Okay, Mahesh.
Yes. Okay, sir. Coming to post-operative nutrition, apart from carbohydrate loading, early post-operative nutrition can ameliorate the metabolic response, leading to less insulin resistance, lowering the nitrogen loss, and reducing the loss of muscle strength. There is no advantage in keeping patients nil by mouth. After elective gastrointestinal resection, early feeding is recommended in even in these kind of surgeries and may actually be beneficial by reducing infectious complications and length of the hospital stay. A lower incidence of anastomotic dehiscence, wound infection, pneumonia, and intra-abdominal abscess or mortality in patients who receive early enteral feeding has been shown in many RCTs and many papers. In a nutshell, this is the protocol by the ERAS system recommending the pre, intra, and post-operative programs, which you already discussed. So very important things are the goal-directed fluid therapy, then to audit all the steps for compliance, because as Dr. Lakshman said that this is still in a voyage and there is some, yeah, what do you say, like hesitancy to practice ERAS protocol in various centers or doctors. So an audit will help to improve the recommendations as well as to follow the protocol conveniently and successfully in any hospital. So what are the benefits of ERAS? One is important one is as we already seen that the patient's morbidity and mortality is reduced. At the same time, there are various health and economic benefits. The implementation of ERAS protocol represents a significant change in practice and a potential increase in the use of resources. There are direct and indirect medical, non-medical costs were significantly reduced in the ERAS group. There was a significant reduction in total hospital stay, which intravenous fluid use, drug use, complication, duration of epidural use in the ERAS group. One study by Schuster and colleagues estimated in America using of chewing gums following colectomy has saved nearly more than $11,828 per year in the United States. Means basically the post-operative parenteral was less, and early feeding and early recovery and early discharges overall helped in reducing the health cost to the system. In this study, we can always see the number of active days or functional capacity where earlier in the ERAS patients than the traditional care patients. Significant number of days were added, or significant functional days were added to the patients who have undergone the surgery through the ERAS recovery process. So what are the benefits to the patient? A structured approach towards patient care before, during, and after surgery. There is a clear communication between the patient and the team which were taking care of this ERAS protocol. There are lower risk of post-operative complications. Patients and their family members are more involved and they were aware of the process and procedure. They were more active in the pre-op as well as post-operative care. There were decreased readmission rates and reduced length of hospital stay, reduced anxiety and mental stress, because what we expect was discussed thoroughly by the multimodality team. And also there was increased confidence in the medical staff towards clinical management. The whole team were comfortable and we're confident with the process, how the ERAS pathway has been taken forward. And so more and more patients were benefited with this protocol. In a nutshell, you can see in this slide, it starts with the admission, before admission, and ends with an audit, or it continues with the audit. So as mentioned earlier, it is evolving and it is helping the patient, benefiting the patient as well as the hospital and the nation. And also it is being practiced in various surgical procedures, and slowly many common surgeries what we do can also be adopted in this protocol, because the system or the practice is very simple, but there should be a good coordination between all the ERAS member teams. To summarize, implementation of ERAS requires a coordinated multidisciplinary approach as mentioned. The important aspect is the team itself. The team should be strong and everybody should have the mind and mental framework to carry on with the process and protocols. The team members should be familiar with the principles and protocols. They must be able to overcome the traditional concepts, teaching and attitude towards perioperative care. And this can be improved by various elements and components by auditing them. The ERAS program continues to expand across various surgical disciplines as discussed earlier. Switching to and adopting these guidelines have been proven to improve patients' outcome and reduce the healthcare costs to the state as well as to the individuals. These are some websites with respect to the ERAS which I have mentioned here. There is interactive audit system is there, there is a study program is there, and there are guidelines which anybody can download and use these guidelines. And these are my references. Thank you.
Thank you, Mahesh. Any other questions? You can stop sharing. See, one of the things which delays post-operative recovery or the discharge is the post-operative nausea and vomiting. So that is one of the important components in ERAS to prevent this. Mahesh, you can stop sharing. Anything extra is done for that? Anesthetics will take.
The carbohydrate loading itself prevents this post-operative nausea and vomiting. Apart from that, less use of non-opioid analgesics and
Right.
These things have helped to reduce to maximum extent about these problems.
One of the things recommended in ERAS also is dexamethasone IV at the just before the extubation or sometimes post-operative also, that can prevent the post-operative nausea and vomiting. Some of the patients are prone for PONV, post-operative nausea, vomiting. So anesthetists have to take much more care in those patients. Saurav is asking obligatory underhydration and its role in ERAS. Saurav, what is in your mind?
Sir, actually, I had read in Bailey that in the immediate post-operative period, there will be a third space fluid loss. So just by going through, if we just go by looking at urine output and all, initially it may be misleading, because we'll be feeling that the patient is having less urine output. Probably patient is in fluid deficient state, and will overload the patient. So even Ravi Shankar sir had mentioned to us many times before that in the immediate 48 hours post-operatively, don't try and overload the patient with fluids just because you're seeing a less urine output.
You're absolutely right. Mahesh.
That's what actually it is mentioned in the ERAS protocol. The fluid therapy as well as the response to the fluid therapy should be micromanaged have to be seen then and there and then managed, but excessive fluids are not given.
So, sir, what is
There are
the
various
correct?
gadgets to monitor this. Yeah.
Okay, okay. So, because I read that even CVP is not a good marker for measuring central volume
But
growth.
it is a generalized marker actually, which we've
Yes,
been
sir.
practicing. But when it comes to ERAS, there are some gadgets which I'm not really aware, which helps in micromanaging the therapy as well as the response, the inotropic response of the various vital organs in the body actually.
Okay, sir.
Use of incentive spirometry prior to surgery and post-surgery.
Yeah, that comes under the prehabilitation, wherein exercises, resistant exercises as well as lung functions, incentive spirometer, and even regular breathing exercise by the physiotherapist. They all come under the prehabilitation in the ERAS protocol.
Dr. Nos, you were asking about OCP, no? When to stop OCP prior to surgery, is it?
Yes, sir.
Anything, Mahesh? Anyway, it's not
I
part
don't
of
have knowledge of this, sir. Sorry, I didn't go into the depth of it.
Lakshman.
Uh,
OCP, when will you stop?
I think it is 2 weeks. I'm not too sure about this. I think I'll have to look it up, but if my memory serves me right, it has to be for 2 weeks. Otherwise, there is a
Okay.
slightly higher DVT risk.
Yes. Correct.
Yeah.
Yes.
Regarding this IV fluids, to just dilate a bit on what Saurav is asking. Just like permissive anemia, permissive dehydration is recommended in ERAS, because if you push fluids to chase urine output, as you pointed out, you may get wet lungs and they may not be able to get better and hydrate, mobilize well and get better sooner, and the edema that it causes may also prolong ileus. So what you have to do, that's a goal directed therapy that Mahesh mentioned about. Keep your MAP above 65 or 70, not the CVP, MAP, mean arterial pressure, and that will keep the systems going, and you direct your fluid therapy based on that.
Thank you, sir. Thank you, sir.
Thank you.
Else, postgraduates. Okay. Tomorrow we have a meeting of morbidity meeting. I think Dr. Janani is presenting.
No, sir. No, sir. Tomorrow I'll present a case of parotid abscess, sir. So tomorrow clinical case presentations.
Clinical case present. Okay.
Yes, sir. Yes.
Right. Dr. Lakshman, the final
Yes,
comments.
Sir. Good meeting. Good summary, Mahesh. Congratulations on that.
Thank you.
Yes, like everything else in surgery, I think it's the mindset that's important.
Yes.
And most of us have to change our mind and work towards ERAS. I have been trying to do it for the last 5 years, but I know that if I get an audit of my work in a hospital, we will fail. And the biggest problems we have is to take the whole team along with us. Our anesthetists are not as enthusiastic as we are many times, so we've got to get them with us. And particularly the protocol is very difficult to be followed in the wards. Nurses keep changing their shifts, and to educate every shift nurse for early mobilization, for example, is an extremely difficult thing. They put them in bed in spite of our repeatedly saying, no, they don't. And one of our challenges, I'm not criticizing my colleagues, but in many other departments, they tell the nurses to do the exact opposite of what we want them to do. They put them in bed for 48 hours, NPO for 2 to 3 days until they get bowel sounds and things like that. So it should be an enthusiastic movement among all the surgical departments of the hospital before it becomes a success.
Yes, sir. Absolutely, sir. Thank you, sir.
It's a program. I think if we affiliate to the Eros society and they monitor everything.
Yes.
Also, we have to fill up the forms and they give a training. So that is where we have not yet gone through. I think Manipal Hospital, they have done it.
Somshekhar has done it and has done it well, I think. But that's a challenge that is difficult to be, replicated everywhere. Yeah.
Correct. Thank you very much. Thanks for interaction and a good meeting. Thank you, Mahesh. Thank you.
Thank you, sir.
Thank you,
everyone.
Yeah.
Thank you, Dr. Nas.
Thank you.